Hi, everyone. My name is Patty Isaberi. I'm faculty at the Division of Prevention Science here at UCSF. And I'm so excited to be joined by Dr. Hyman Scott, who's a clinical research medical director at Bridge HIV in the San Francisco Department of Public Health. And he's also an assistant clinical professor of medicine at UCSF. Hyman, we need to talk about why you're not associate clinical professor. We need
There's
to
a
promote
reason.
you.
I could explain.
ASAP. He is a former TAPS fellow, which is our claim to fame to have him as part of our team. And he is an interest in epidemiology of HIV-related racial ethnic disparities among men who have sex with men and interventions to reduce these disparities. He, in addition to all this work, he is also a provider at the Positive Health Program, leads a PrEP implementation program within San Francisco Department of Health Primary Care Clinics, and serves as a medical director at San Francisco AIDS Foundation. And Hyman and I had the great pleasure of working with Hyman on my PrEP project, and it was great to talk to him on a weekly basis or sometimes daily. And I came to find out that he is into horseback riding, which is amazing. I've always wanted to see him in his horseback riding routine. So maybe one day we'll do that, but a little known fact about Hyman. So thanks, Hyman. Please feel free to take the stage.
Thanks, Badia. So I'm excited to talk a little bit about PrEP, and always happy to talk about horses if anyone ever wants to talk about that. So I'm going to sort of spend about, I guess, 40 minutes or so talking about PrEP choice and how the PrEP landscape has evolved, and how we are and are not meeting the needs of those who might benefit the most from PrEP. And would love to have a discussion towards the end as well about some of the PrEP implementation. So this is sort of how I think about PrEP in the setting of the mosaic of HIV prevention. So we have several options for PrEP now, including daily, on-demand, and injectable, and I'll go through those in a second. STI testing and treatment is also a cornerstone of our HIV prevention efforts, given the association of STIs with increased risk of HIV acquisition. Condoms, of course, for those who prefer to use them. And then we have DoxyPEP, which is a new sort of tool in our STI prevention that I think will have some HIV prevention sort of side benefits as well. Vaginal rings have been recommended, but haven't been widely available in parts of Africa. They've been withdrawn from application to the US FDA, so it would not be an option in the US. And then we are still ways off from HIV vaccine, although the quest continues. And then we have new implants, which are also under development, which are really sort of point of use and episodic use for prevention of HIV. In San Francisco, we've seen a decline in our HIV diagnoses. From the 2006, we've gone from over 500 diagnoses to about 160. We did see a dip during COVID in 2020 and a almost expected rebound given the significant reduction in HIV testing access that occurred during COVID. So, but we're still sort of on the downward trajectory for HIV diagnoses in a way that is different than I think what we're seeing globally, and also what we're seeing in many parts of the US. So now just thinking about all the different PrEP options, we have daily oral PrEP with TDF-FTC, and we have now more than a decade's worth of data in multiple studies showing that if there's higher adherence measured variety of ways, including dried blood spots, plasma, and hair, that effectiveness is actually quite high and above 90%, 99% among MSM. We do have individual studies, which you can see on the bottom left of this graph, where the effectiveness is actually negative, where there are more infections in those who are randomized to the active TDF-FTC than among those in the control arm. And that was really driven by really low levels of adherence that occurred in those studies. And I think that this has translated into a very sort of slow approach towards PrEP among cisgender women. Those are two studies, Voice primarily, where we saw these data. And some recommendations around PrEP use among cisgender women that set a higher bar for adherence in order to have any efficacy. I'm going to present some data, more recent data that came out of CROI around oral TDF-FTC for women that suggests that our approach towards that adherence might actually not be appropriate. And so this is a study by Jeannie Marazzo that looked at demonstration project data from multiple studies globally and found that there were sort of different adherence trajectories that individuals had. There was those who were like consistently low. Those were those who started high but dropped. There were those who were started high and stayed high, but not daily. And then there were those who, stayed at consistent daily use. And I think our current recommendations was that for cisgender women or individuals who are having receptive vaginal sex, that having levels more consistent with 7 doses a week was necessary for protection, given that there is some PK data that levels are lower in the vaginal vault than they are in, say, the rectal tissue. It doesn't take into account PBMC levels, which would be independent of the site of exposure and are likely a strong contributor to the protection that we see with TDF-FTC. And there were a relatively large number of participants in each of these groups. And what they saw was that, even with consistently high, which if you go back was 4 to 6 tabs, which is what we generally say is necessary for men who have sex with men and have an exposure through rectal sex, that we saw really low HIV incidence in that group. And that the incidence did increase as individuals had lower adherence. And there were no infections in those who had daily adherence. And this is among 3,000 women. So this is really changing my recommendations and considerations for cisgender women and oral PrEP. And I'm shying away now from saying that consistently daily use is necessary for high levels of protection. I think this data give us strong evidence that that PrEP can be as forgiving among cisgender women as it is among MSM and transgender women who have primarily rectal exposure. So these are some data that came out of CROI, and hopefully these will be published soon as providing support for a more sort of forgiving message for cisgender women in oral PrEP. The other option is on-demand PrEP with TDF-FTC. This has been rolled out primarily in Europe, so in France, French-speaking Canada, and then in Netherlands and other parts of Europe. This is really being offered as a sort of even-handed option. And for those who are unaware, just a summary, the PrEP is 2 tablets, 2 to 24 hours before sex, and then 1 tablet 24 hours after the first set of tablets, and then 1 48 hours after the first set of tablets. And then if you have more sex, you just continue to take pills daily. And the prevention efficacy is extremely high. It's above, it's close to 97, 99%. And in a large study called Prevenir, which was done it was not a randomized control trial. It was done in Paris, where they offered this even-handedly. They really didn't see, they saw similar levels of protection. So this works really well. It is not really recommended universally by guideline bodies. So the CDC guidelines don't, explicitly recommend 211. It's not been FDA approved. Not clear there's a pathway for this as a generic drug to even have an application for an indication, but the evidence is strong, consistent, that this works really well. So in certain settings, we are offering this. So for example, Patty, I mentioned I'm the medical director at the San Francisco AIDS Foundation. We offer this as an option for oral PrEP, and about 20% of people take it up. So there is a interest and a demand for this, and it's the option that works really well. TAF FTC with this trade name of Descovy has been approved in the US for individuals who are having sexual exposures to HIV except receptive vaginal sex. So this would include cisgender women, transgender men who are having vaginal or frontal sex. And it works, it's non-inferior to TAF, to TDF FTC. And given the cost differential, I think many groups, plans, individuals are, not using this as widely for PrEP as TDF FTC, but it's sort of an option for those for whom there might be a reason not to use TDF FTC. CAB-LA, which is the injectable cabotegravir, is a game changer. This is a study studied in 2 studies, HPTN-083, which was among MSM and transgender women in global sites, and then HPTN-084, which was a study among cisgender women in sub-Saharan Africa. HPTN-083 was non-inferiority. It was comparator was TDF FTC, which shows high efficacy. So the trial design was actually to look at non-inferiority. However, it exceeded the superiority margin. So was actually found to be superior to TDF FTC, even though that wasn't the study design, with an efficacy of 66% higher than TDF FTC, almost certainly driven by differences in adherence to oral PrEP compared with injectable PrEP for visits, but it was a stark finding. And then HPTN-084 was designed as a superiority study given the challenges with efficacy that's been seen in the oral PrEP studies, and it did show an even higher efficacy compared to oral PrEP of 88%. So really a game changer. I'll talk a little bit more about all the problems we're having rolling this out in the US in particular, but there's also a lot of challenges globally as well. One of the things that we did in 083 was to look at subgroups of individuals that are, comparing individuals by demographics to see if there was specific subgroups that might benefit more. And in general, there was lower HIV incidence among younger individuals, MSM, and then US Black participants as well. So these are all the many of the priority populations in the US that we are struggling to get PrEP to and to maintain on PrEP. And this is why I think CAB-LA might have a big gap that it can fill for our PrEP efforts. This is a sub-analysis that we looked at HIV incidence among US Black, MSM, and transgender women. What we found is that among Black individuals, Black MSM and transgender women, there were 15 infections. So HIV incidence among those who were on TDF FTC as part of a clinical trial, incidence was still over 2. And then it dropped to less than 0.6 among those who were in CAB-LA. And then among the non-Black MSM and transgender women, there were 5 infections. So overall incidence was much lower in the oral PrEP group, and then there was 0 in the CAB-LA group. So we did see a significant reduction in HIV incidence among the Black MSM and trans women in the US in this study, really supporting that this is an important tool for helping us address some of the disparities that we have in HIV incidence in the US. So overall, how are we doing with PrEP? And I think the bottom line is we're not doing that great. So this is data that was published in Lancet in 2021 that sort of demonstrates the global inequities that we have in PrEP use. You can see that in the US, we have the largest number of individuals that have received PrEP, but in many of the places where we have the generalized HIV epidemics in large epidemics, we don't have rollout. And we still have a long way to go for our global and local and sort of domestic HIV prevention goals. So we're way off target from where we need to be. And a lot of this is driven by, in the US in particular, by the inequities that we have in PrEP use. So this is data from the CDC around uptake, and only 25% of those who could benefit are receiving oral PrEP or any PrEP. Our goals for ending the epidemic are to reach 50%. The only group that has reached that are among white individuals. And we have done even worse among cisgender women. Only 10% of cisgender women who could benefit from PrEP receiving it. So I think that addressing these disparities is going to be essential to achieving our goals locally, domestically, as well as globally. I think the US CDC updated guidance has been helpful. In the prior iteration of the guidelines, it was really risk focused. And there's been a notable shift in the language of the new guidelines to be more sort of universal offer focus, which is an approach we had taken in San Francisco in our PrEP efforts. So they essentially say that all sexually active adults and adolescents should have PrEP discussed and considered as an option. And if someone asks for PrEP, they should receive it. And that we really should not be getting into all the details about what risk criteria someone might meet or not meet. But they have an algorithm that sort of shows how to think about it. And if someone is sexually active, the way that you read it is that all roads lead to PrEP. So we discuss PrEP with everyone, and we offer it to those who decide that it might work for them. So these are the 4 options that we have for daily PrEP that I sort of talked about in the groups for whom they are indicated. So for daily oral PrEP for TDF-FTC, what I sort of say is it's for everyone, without any regional disease or other sort of medical contraindication. TAF-FTC is for individuals who are not having receptive vaginal sex. So if I have a trans man who does not have front hole sex and is not a preference for theirs, then daily TAF-FTC would be an option for them, but it hasn't been studied among people who inject drugs. 211 with TDF-FTC, I think that it's primarily been studied among cisgender men. There have been trans women enrolled in the studies. There's a lot of providers that exercise caution with using with trans women, given some of the PK data that suggests that we have that estrogen therapy reduces levels by about 30%. My personal approach is that I counsel my patients that taking it with food increases levels by 30% for TDF and about 18% for FTC. So if there's a concern, then taking it with food would give them a higher level of protection if 211 is really what they would like to use. And then CAB-LA has also been studied among many groups, except people who inject drugs. So with all these options, what's going on in the US and what are the challenges to implementing it's not even new anymore, to HIV prevention with oral PrEP, for example. I like this slide because it really highlights that those who are doing PrEP implementation really understand how our systems are not working for people. So if someone's not engaged in PrEP, then they don't recognize that their staff don't know about PrEP. So there's a large difference in those who are doing and those who are not doing. Also, the capacity to implement is starkly different between those who are doing PrEP and those who are not. And then this lack of willingness of providers to prescribe PrEP, I think, is an unrecognized barrier for a lot of people until you start implementing it and you see all the barriers that exist. Cost for our non-generic TDF-FTC is still a big issue, and that when people are doing it, there's a myriad of issues that come up for individuals. And these are in a variety of different domains. So both patient and provider awareness, communication, risk perception. So individuals seeing themselves at risk. I think we've done this through to ourselves and not having consistent messaging and focusing too much on risk. that has resulted in some stigmatization of individuals on PrEP. This is sort of manifest early on with certain terms like Truvada whore, and these other commentaries around what someone on PrEP was doing, and individuals not wanting to be necessarily associated with that. And I think it's particularly been challenging for cisgender women, because there's very few messaging for that group in the US. There's a lot of provider bias and medical mistrust, access to medical care. These medications and the tests that are associated with them are quite expensive. And so we have to take into account some of those costs as well. And the side effects are a concern, I think, particularly with a lot of the ads that have been run around kidney failure that has been seen in TDF-FTC. There's a big New York Times article, if you haven't read it, that sort of outlines some of those lawsuits, but also gives an insight into the company that produces TDF-FTC when it was not generic, and their decisions around delaying TAF-FTC development. So even when people start PrEP, there are discontinuations are high, persistence is low, and up to 60% of people are no longer on PrEP at 6 months or a year, and same is true for women, cisgender women. And when people stop PrEP, there's high number of HIV infections that occur. So we have to focus both on helping people start PrEP, but also helping people stay on PrEP, and that's the systems that we have in the U.S., for example. So these are some data from the U.S. around provider gaps. So this is sort of this purview paradox where providers who do HIV care have a lot of knowledge, awareness, and PCPs who are not necessarily. This is from 2017, who are less comfortable discussing sexual health, testing for acute HIV, delivering new HIV diagnoses. And I think this has evolved. I think that there are PCPs who have embraced PrEP, who are knowledgeable about PrEP, and who are prescribing PrEP. But I still think that there are a lot of providers for whom this doesn't apply, and that there's still less of a familiarity and desire and interest to do PrEP. And then there are other provider level factors, including cultural competency and LGBTQ health, and then short clinical encounters. And this is the CDC guidance that essentially all roads lead to PrEP that I mentioned. Patients really want to have a discussion with their provider around PrEP that's non-judgmental. And I think those who do counseling, sometimes you can recognize when people are a little concerned about, how what they might share might be received, and they might be judged about that. We make it difficult for people to get access to their providers, testing, and getting their medications. I think we learned some lessons during COVID that hopefully we can continue. And then, talking to patients about sex. My perspective has been that, there's some information that we need to know in order to help people make a decision about their PrEP use, but we don't necessarily need to know all the details about their sexual activity. I think that those of us and those providers who feel comfortable and do it all the time, I think that that's one area that if you feel comfortable doing it, that we can do it. But I don't know that we necessarily need to push for all providers to have these very detailed sexual health conversations if they're not comfortable with the language and how to do it without traumatizing some of our patients, particularly our LGBTQ patients who may have had negative traumatizing experiences within the healthcare system. So there are some community campaigns. I love this campaign from the PrEP for Love, which had an extremely sex positive, body positive imagery, and sort of talking about like all the ways that people connect to each other. And then San Francisco has an ongoing campaign called Good Sex, and has also had these Viva PrEP campaign, which was focused on the Latino community in San Francisco in collaboration with Instituto, and then a PrEP support campaign that really focused on all the ways that sort of PrEP fits into individuals' lives. And these were focused on predominantly African-American and communities in San Francisco. So what have we learned from the slow oral PrEP rollout in the US? So I think that we've learned that without a coordinated education and outreach campaigns, that we're going to really miss our community targets, that we need to be inclusive of our language that reflects the science, and we need to talk to people about those who might benefit and use language that's not stigmatizing, and that providers really need support around standards of practice and education. There are some concerns about risk compensation, resistance, and side effects that I think happened early on in PrEP, are hopefully less of an issue now, but have really slowed our rollout. Messaging really needs to be non-stigmatizing and clear. There have been campaigns that sort of made people feel stigmatized about being on PrEP. And then really important to address some of the myths and community and client concerns. I think that's been really great to see all the research has followed the concerns among transgender women around the impact of PrEP on gender-affirming hormone therapy. And now we have the data to support counseling messages around that. And then we need to expand access. So medication costs are a really important part of this rollout, and then making sure we have providers who are willing and have capacity. So my perspective is, it's not clear that we've actually learned any of these lessons. We have examples with injectable PrEP, with doxy-PEP, with Mpox, that really have shown that we have still a long way to go. And so we have this new injectable PrEP option that is better than what we have available. Rollout has been atrocious, in my opinion, in many places, even though it can, I'll show some data on desirability for these options, and cost is extraordinary. So this has just not been really easy for anyone to get. Doxy-PEP got the power, in my opinion, to revolutionize STI prevention in the same way that PrEP has for HIV prevention. And we have different recommendations across jurisdictions. San Francisco Department of Public Health was the first jurisdiction to put out health guidance. California state put out guidance as well. They are different guidance. Seattle recently put out guidance, which is also different. There's a lot of provider concerns about antimicrobial resistance, impact of the microbiome, risk compensation. There's differences in awareness in the community. This is cheap. This is very cheap, but still not being prescribed. So provider willingness is really a issue. So I think that there's some systematic things that are sort of limiting our ability to roll these new interventions out. And we know that if we give people choice, because we have data from contraception, that actually increases uptake, and that we have these options now available. So if we can actually give an authentic choice, we have the ability to potentially really increase uptake of PrEP across the spectrum. And we're going to have new options, hopefully. So islatravir, which was an NRTTI, was going in a phase 3 trial. They're going back to the drawing board because it caused low white counts. So there's a new drug that's actually coming up into a phase 1 trial that's very similar. We have cabotegravir. We talked about the dapivirine ring. There's a ropivirine, and then there's lenacapavir, which is in a phase 3 trial now, the PURPOSE trials, which is going on. So we're hopefully going to have even more options, and people are really interested in these non-daily PrEP options. So this is a study among MSM that showed that 60% were interested in long-acting injectables, and that the U.S. study, this U.S. study that looked at interest among MSM recruited online, showed that no option had a majority interest, and that daily was only about 30% of people. Implants were also had a high interest, in long-acting injectables for about a quarter. So I think what we're seeing is that daily PrEP is not going to meet the needs of individuals. And then when we look at, some of the data that's available for cisgender women, long-acting injectables are even more, interest is even higher. This is from HPTN 076. And then this is a product preferences from VOICE-D trial where injectables had the highest interest. So we really have an unmet need in our communities for long-acting PrEP. And then some data from MTN 034, which is a microbicide trial network where individuals could choose oral PrEP or a ring after they sort of completed the first phase of the study. And there was higher adherence to oral PrEP when that was what someone chose. So really showing that giving a choice is really helpful in people taking what they've chosen and hopefully continuing it, although we don't have data. So as we think about these different choices that we have, right now we have TDF-FTC, TAF-FTC, and injectable PrEP. There are pros and cons to each of them. And, I think how we match this with individuals' desires is really important. I think the cost associated with it is also important. Injectable PrEP recommendations are for viral load testing, more frequent visits that are in person. It's not generic. But the con is that you don't have the flexibility with oral PrEP to do remote visits, to do telemedicine. And so, matching it with individuals, I think will be really important. The cost of TDF-FTC, of CAB-LA compared to TDF-FTC is substantial. This was a costing study that was published in Annals of Internal Medicine, comparing generic TDF-FTC to branded TAF FTC and no PrEP. And so there is significant upfront costs, both for the provider potentially, and hopefully, will be covered by the national program to help offset some of these costs. There's a pharmacy benefit associated with some of these prescriptions in California. When you have a medical benefit, it actually does two things. One, it potentially puts the cost on the provider. Two, it reduces or eliminates the ability for individuals to do 340B reimbursement. So there's actually a bill that's moving through the California Senate, I believe, that is going to be focused on requiring that all HIV prevention be covered as a pharmacy benefit, so that it can support some of these rollouts. There's access programs, and we'll talk a little bit more about CAB-LA. There's testing challenges as well, visit structures that are potentially need to result in changes in the structure of our clinics that are providing this, or use of injection centers or infusion centers, for example, which is what some clinics are doing. And then how we cover missed or delayed injections is also something that is really, I think, been challenging for some clinical sites as they start to implement long-acting injectable. There's also this concern about breakthrough infections that occur. In the trials for HPTN 083, we saw breakthrough infections that occurred despite on-time injections and serum levels of cabotegravir that we associate with protection. And so it's really not, we really don't understand why these happen. And it's something that I think is being further studied, and is something that I think a lot of clinical sites are struggling with how to manage. And then when you discontinue CAB-LA, you have a long tail that can, we know when people stop PrEP that they can increase their risk of acquiring HIV. And so there's a concern that it'll drive resistance, which if individuals develop resistance to cabotegravir, it is cross class resistance. So it makes it difficult to use any of the, or impossible to use any of the other integrase inhibitors. We have some supply chain, staff, and space, and then patient support challenges, patient navigation, which Padia has a lot of experience with implementing, is really important for helping people get and stay on PrEP. And the goal really is to really grow the pie of individuals who are on PrEP. This is a modeling study that was published at CROI that showed that that increasing, they looked at HIV risk reduction in 32 US cities, that increasing PrEP, anyone on PrEP was associated with reducing HIV incidence. But if you increase by switching individuals, you get less of a gain than sort of adding to the pie of individuals who are on oral PrEP. So covering more people, not just switching individuals from oral PrEP to CAB-LA, for example, results in the biggest impact on our epidemics. So these are some local data from Al Liu and some our team here, as well as some of the data from HPT and 076. So in a quickie survey study that was done in 2018 and 2019, about almost 900 MSM and transgender women, those who were never on PrEP before would start with, or 50% would start with a long-acting injectable. And then it was even higher among those who were former users and had been off PrEP. We see that we have pretty low differential uptake, in particular among women and individuals who are unhoused in San Francisco and in the Bay Area, looking at some of the NHBS data. So we still have these big gaps that we can hopefully address. And so what we really want to do is to increase PrEP uptake. And in summary, I think PrEP uptake has been low and unequitable, both in San Francisco Bay Area, nationally and globally. And then we have these new PrEP options that can potentially expand our coverage and fill these gaps in among people for whom daily oral PrEP is either not desired or not working. And that is going to require us shifting our provider systems and reimbursements to address these implementation challenges, which continue to threaten our ability to reach our end the epidemic goals. And the goal is ultimately to give an authentic choice for the ever-expanding menu of PrEP options. And I think CAB-LA rollout has given us a real insight into what challenges we're going to have with some of these other agents that are in the works. There's also a broadly neutralizing antibody regimen that might be going into clinical trials that would provide potentially even more challenging implementation. So and I think the answer to the question that I set out to ask is, are we ready, is I'm not sure. I don't think we are ready to roll this out in an equitable way to reach the communities that we know most need PrEP, and that we'll need a lot of implementation, a lot of community activation, engagement, and provider and scientific buy-in to try to achieve those goals. So thank you, and thanks you to Padia and for Rochelle for inviting me to talk a little bit about some of the work that we're doing here, and happy to take any questions.
Wow, thank you, Hyman. That was fantastic. That was so short, though. I'm like, more. I was actually, maybe just before we open up for questions, I was wondering if you can also just give I know this is probably, it deserves its own lecture, but maybe a little bit about the research work that you're currently doing to try to address some of those disparities.
Yeah, so we're doing a sort of a multi-pronged work. We're doing some of the at our site we do sort of clinical trials from first in human through phase 3 and phase 4 trials. So we're in our sort of later phase trials, we're doing an implementation project with CAB-LA that's focused on trying to assess what are the implementation strategies that might work best to support implementation. And then we're doing other studies that are focused on sort of adherence and sort of using technology to support adherence among, in particular, a younger MSM with a focus on Black and Latinx individuals. And we use our mixed methods approaches, so we really integrate the client participant perspective in what we're designing from the very beginning. And our studies that often are focused solely on the populations that we want to work with. So Black and Latinx individuals, for example, we'll do all of our formative work, develop the interventions, and then test those interventions in those populations. And so that's generally been our approach. And we have a community advisory board that is focused on sort of helping us and giving us community feedback on that. We work really hard to ensure that our staff represent the communities that we want to engage. And so we have, that is one of the pillars of the work that we do. And then I think that helps us do our work better. And then we listen, and then we try to listen to what's going on in the community, what we're hearing, and we try to be responsive to that. But we try to have the, community inform our science and then feed our science back to our community so that we can do better science. And I think that's been sort of a pillar of the work that we do. And we try to use technology to the best that we can, but realize that not everyone has access to it in the same way. And so trying to support individuals in sort of accessing PrEP and PrEP support outside of, necessarily a medicalized setting, and using a pharmacy, for example. Susan Buckbinder, who is our director here, there's a pharmacy-based PrEP study that is using collaborative practice agreement, is another example of sort of how we're thinking about.
Great, thanks. Hyman, is it possible to stop sharing your screen? Because
oh yeah, sure.
I think someone might actually show you their cheeks if you keep that up. I
It's a safe
thought this
space.
might
It's
be
a safe space.
it's a safe space. So there was actually a question in the chat, and I'll read it, and if other folks want to just come off mute, please do so. But the question is, why has CAB-LA not been tried or recommended in PWID?
So I don't think that the studies have been done yet. I mean, we actually don't have great data for TDF-FTC in PWID yet. We have one study that was done and just used tenofovir. And so I think it's a gap, and I think it's definitely something that we've tried to put on the attention of NIH to ensure that we do have this data. So I think that there are some studies being planned for it, but I think that we were hopeful that CAB-LA would work so well. I don't think we were expecting these types of efficacy. Like, there was not an expectation that it would be superior to TDF-FTC among MSM and transgender women. So I think it was, to use a sports analogy, it was a home run, right? That wasn't expected to happen. And so I think, as you meant, as this question might be getting at, like, it should accelerate our desires to make sure that we can use this in other populations where it's needed.
So folks, please come off mute or put your questions in the chat. I have tons of questions, but I want to give other folks a chance. So Dale is asking, will you advise your patients on daily oral PrEP, that there is now an alternative with higher efficacy?
So I don't. My approach has been that the best PrEP regimen is one that someone will take, and they're more likely to take it if it's what they want. So efficacy is only one part of the set of considerations that someone is going to be considering as they make a decision about what PrEP option they want. And so I make sure everyone's educated about it, but, you know, I tell them the pros and cons as I sort of outlined briefly, and then let people decide. Some people don't like needles. Some people like the flexibility of having oral pills. And, you know, I think centering it on the client or participant or patient is really essential, because what they might value might be very different and unpredictable. So as I've talked to people, sometimes what they value is actually the ability to have pills in hand if they're traveling with their friends and their friends run out of PrEP. So they want to be able to share their PrEP as part of their community efforts to support their friends' HIV prevention. That is not something that ever comes up in a pro or con for why someone might choose to be on daily PrEP. But for them, that is, you know, that's a serious consideration. So, so I like make sure people know about it, but also recognize that, you know, it doesn't matter what the efficacy is if you don't come in for your visits, if you are, you know, missing shots or have a lot of pain and, you know, don't want to continue.
Great, thank you. Hyman, I have a clinical question for you.
Okay.
I think I may have asked you this before, but what are you telling folks who are starting cabotegravir without an oral lead-in or any Truvada beforehand, as far as like time to protection?
Yes, this came up a lot in our clinic. So I tell them that we we can just start it without it. We don't have great data. We don't have, it's not been studied. So it's not been studied in that way. There was one PK data, one PK study that did look at, you know, the differences in levels based on the oral lead-in versus the direct to inject. But I will also say that in the HPTN 083 study, there was a transition period where we moved people from injections to oral Truvada, TDF-FTC, and then back to injections. And that was direct to inject. So we didn't give an oral lead-in, and we didn't see a lot of HIV infections occurring in that setting. So I know that the PK data suggests that the levels might be lower, but I think in the absence of clinical data that's a problem. I think we potentially undermine our efforts in efficacy for how well we think HAB-LA works. I think we did our disservice to ourselves with oral PrEP when we did that, when we said it takes 7 days for you to have protection. And I think for women, cisgender women, it was like 28 days. So I think that thinking about how we message that, and now we have data that, you know, some of those messages actually might not be accurate. So I base it in what clinical data we have, and the PK data is useful in informing that. But, you know, it's not like we saw, you know, infections happening when we have a background incidence of 2.11%. So it's not like there weren't infections happening in that population. So so that's sort of my message. So we actually got into a heated discussion about this because it came up in how we're going to approach the protocols for doing this.
And
oh, I won.
when is the protocol come out?
I won. There's no oral lead-in. And because, you know, I think that it's not supported by the clinical data that we have from the clinic.
So you basically tell people as soon as they get the injection, they're protected.
So I tell people, you're doing excellent. I'm glad that you're here to take control of your sexual health, and we're going to give you the shots, and your decisions to do what you want are your decisions to do what you want. And I don't get into like delay and, you know, wait and those kinds of things. You know, it's not like 211 where there was like a clear protocol that people were following. We didn't recommend that at any of the trials. We gave people their shots and they went and did what they were going to do. And it worked. And it worked so well that they ended the study early.
All right, Hyman, 2 questions, one from Kristen in chat, and then Holly has her hand raised. So Kristen's asking what your thoughts are on bacterial is it good for our bacterial health to be taking antibiotics daily, re-doxy PrEP or doxy PEP, I think.
Oh,
Maybe.
no, I think she might be asking about doxy PrEP because the doxy PEP is after, but there have been some protocols that have looked at doxy PrEP. I think Canada is doing a doxy PrEP study as well, but I can address both because I have opinions about both. I'll first start with doxy PEP. And I always like to couch that the vast majority of antibiotics that would be used in doxy PEP, if every gay men who have sex with men was on it, pales in comparison to the amount of antibiotics that are used for inappropriately for ear infections and in the animal, like the tons of antibiotics that are used in animal feed. That's what's driving a lot of the, sort of antimicrobial resistance. So, you talk to antimicrobial resistance experts like Chip Chambers, and they're like, this isn't a problem. Like there's being this big discussion around it where this isn't what's driving antimicrobial resistance. And so there is the impact on an individual. So there's a concern about the gut microbiome that can occur. But I would say that that is true in doxy PEP. There was a 50% lower use of ceftriaxone because of the gonorrhea infections that were prevented. So it's not like no antibiotics and some antibiotics. It's like slightly different set of antibiotics that someone might be on. So I think when I think about it like that, then yeah, ceftriaxone is going to be even broader, so it might have more implications for individuals. So it is a balance. A pro has not come without risks, but I'm less concerned about developing maybe a slight increase in MIC for tetracyclines compared to preventing, in particular, syphilis, the neurologic complications of syphilis, and the number of patients I have who are still partially blind from neurosyphilis that could potentially be been prevented, who have required hospitalizations, and the costs associated with that and IV antibiotics, as well as the complications that we can get from disseminated gonorrhea infections. So if this was just syphilis alone, I still think it would be a highly efficacious intervention to roll out. I think some of the messaging, and this is why I think we haven't really learned our lesson, is still very stigmatizing. I was at a conference last week, and there was a discussion around who this should be for, and there was a comment that that it would be more acceptable for men who have sex with men who are married and not out to prevent congenital syphilis among their female partners. And I was like, this is completely missing the point around, we're sort of triaging who is more valuable to protect. And I think that that's what gets reflected and received in the community. So I'm happy to show you some of the very community grounded messaging that the San Francisco AIDS Foundation has put out to really reflect that this is, a highly efficacious tool for STI prevention. There are risks, people need to know about them, and then let them make their decisions. And it's 78% of the people we talked to decided that it was better for them to take it than not. And we've seen about an 80% reduction in chlamydia infections and a 60% reduction in gonorrhea infections in 6 months.
Wow.
So it works really well. And we know what's going to happen if we slow walk this like we did PrEP. We're going to be having this conversation in 10 years where I didn't show the slides for STIs, but ours are flat for HIV are going down. STIs are just going up. And we have a tool that works really well.
Mm-hmm. Holly, you had your hands up. Do you want to ask your question?
Yeah, sorry, it's a quick question. Thank you, Dr. Scott, for the presentation. Super helpful, especially as I develop my K around this topic. I was wondering what type of implementation approaches or implementation studies you've seen that have been effective in increasing uptake and persistence in the populations that you study.
Yeah, I think that, Padilla study, which is really focused on using navigators, I think like PrEP is easy. Like you don't need a physician to be managing PrEP. It's like, it can be protocolized very easily. Most people have no contraindications. I'd say our PrEP navigators probably were more knowledgeable about PrEP than most of the providers in the clinics they were working in, and the providers were asking them the questions about PrEP because we were having conversations with them about it. So I think it's decentralizing the sort of the PrEP rollout, making sure that the systems are in place, that there's a panel management component. You know, Padia's data also showed that during COVID, with the contact with the navigators, that there really wasn't a steep drop off or any drop off in PrEP persistence during COVID that everyone else saw. And so I think that it's sometimes just some of the simplest things, like people need support and they need someone to like help them navigate some of the issues, because what's going to happen is they're going to experience it and then they're not going to say anything to anyone. And so if we have someone being proactive with that, I think that's been one of the biggest things. I think provider education is helpful. I feel less strongly about that, honestly. If you have a navigator that knows about PrEP in a clinic and they are given the autonomy and support to do their job, then I don't think you need to educate all the providers. They just need to sign the prescription and then get people PrEP and give them refills so that they don't have to keep chasing them down, and be flexible. Like if someone missed their HIV testing, don't cut them off if they're taking PrEP. Give them the refill and encourage them to come back in, but like don't make it hard for people. The more hurdles you make people jump through, the fewer people are going to make it to the finish line. We see we're doing terrible in helping people get to the finish line.
Okay, one final question, because I'm just dying to ask this. What are your thoughts now we have oral contraceptives over the counter? What are your thoughts on having Doxy and Truvada over the counter, which is where I want to see them?
Mm-hmm. Yeah, I think that we should. I think we just need more access to testing. So I think in places where testing is pretty easy to get, I think that it's pretty easy, and we do PEP without doing a lot. So I think starting people quickly is fine. You do want to make sure you have the ability to do testing. Like you can do a home pregnancy test, right? You can get that over the counter, but you can't get the testing that you would need for HIV and STI prevention like over the counter in the same way yet. So I think we need better testing as well, and then we should definitely decentralize this. I think California, there's a SB 339 moving through, which is going to allow pharmacies to both start and continue people on PrEP. So I testified a couple of times for that legislation, and I think that it's been pretty clear that in places that allow that you can expand access, but in the absence of being able to continue and to bill, like it's not going to be a feasible way for pharmacists to continue.
Thank you so much, Hyman. That was really wonderful. And there were some requests for your slides, so you may get some emails if you're willing to share the slides from Holly and Maya. And Rochelle put in the link for our channel, YouTube channel, where the presentation will be posted. So thank you all so much. And thank you so much, Hyman, for a wonderful presentation. And I hope to hear from you soon and all the great things you're doing.
Thank you for inviting me. I love talking about this. So I appreciate the opportunity to share.